Everyone. I'm Captain David Wong. I'm a pediatrician with HHS, and I'm currently deployed to support the therapeutics arm of Operation Warp Speed. Welcome to the fourth session of our monoclonal antibody ECHO national mini-series. We started this series in mid-December, and our vision is for this series to be the go-to forum for providers around the country in all different settings who are learning how to administer monoclonal antibodies to come together, share best practices, share resources, and have their questions answered. We have a full agenda for today, including experts in infectious diseases and long-term care. So without further ado, I'd like to hand the baton over to my colleague, Dr. Bruce Struminger, who will be a co-moderator for today's session. Thank you and welcome.
Thank you, David, and welcome everyone. As David said, I'm Bruce Struminger. I'm with Project ECHO at the University of New Mexico and co-moderating with my colleague, Dr. Christian Ramers, who's the Chief Medical Officer with Family Health Centers of San Diego. So I'm just going to quickly go over a few quick logistic items. Most important is we really appreciate your questions and answers. Questions, and we'll hopefully have some answers. So please put those questions and any comments in the Q&A function along the bottom of the Zoom toolbar, and we'll try to answer as many of them as we're able to during the session. If you have any technical or logistic issues, please put those in the chat, and again, we'll be monitoring that. We are recording today's session, and your attendance is consent to be recorded. Thank you for that. Today's presentations should be linked to the most recent email announcement that went out, and we will be linking those in our website, and we'll share that link in the chat, along with the recording, which should be up within a day or two. There will be CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. We'll put a link in the chat 15 minutes before the end of the session, and there should be a link in the announcement that went out this morning. These learning sessions are focused on improving patient care and health systems and supporting clinicians. Just a reminder to keep them apolitical and non-commercial. Thank you for that. And a very quick note about data use. The data you share when you register, when you put questions in the chat, et cetera, we take data stewardship very seriously. And the data that is shared with HHS ASPR is all de-identified. Very briefly, to run through the agenda, as David said, this is the fourth session in this mini-series on outpatient therapeutics with a focus on a healthcare systems approach. Our initial presentation will be by Raj Gandhi at Mass General, and he will give an overview on monoclonal antibodies for treatment of COVID-19. We'll have a few minutes for questions, and then Inga Lennis will be giving a site-level overview of implementing monoclonal antibody therapy at Mass General and the Brigham. That'll be followed by a few minutes of questions with her, and then we'll open up to a 25-minute Q&A session with a great panel of experts. So with that, it's my pleasure to introduce Dr. Raj Gandhi. Raj is at Mass General and a professor of medicine at Harvard Medical School. And thank you, Raj, for sharing your experience with us today.
It's my pleasure to be here. Thank you for inviting me. Are you able to see my slides?
We see them well and hear you well.
Great. So I'm going to talk about some of the data behind monoclonal antibodies for treatment of COVID-19. I'll spend a minute or two on just some of the risk factors and what we know about risk factors for progression to hospitalization, and then I'll give you just a slide on my perspective. I'd like to put the discussion in the framework of the COVID-19 spectrum, and you'll see why in a moment, but we know that COVID-19 starts with the asymptomatic and then pre-symptomatic phase where the test is positive, but the patient has no symptoms. Mild illness, such as fever, cough, taste, smell changes are the beginning of the illness, and usually there's no dyspnea at this point. Moderate illness is when there's clinical or radiographic evidence of lower respiratory tract disease, but the oxygen saturation is still preserved at 94% or greater. Severe disease, which is when they're typically ending up in the hospital, is when the patient has tachypnea, hypoxemia, or extensive lung infiltrates, and then of course critical illness is respiratory failure, etc. The reason why this is important, the reason I start off this discussion of antibodies with this, is that we think viral replication is most prominent early in disease, 1 to 2 days before symptoms start, during mild illness, and then even without an intervention tapers off, at least in the upper respiratory tract, over the next 7 to 11 days. Inflammation is probably at its greatest during severe disease and during critical illness. This is why antivirals are largely focusing on early stages of disease. Dexamethasone, a life-saving drug, is largely beneficial, or really only beneficial, when someone has severe disease or critical illness through its anti-inflammatory effect. So antibodies, I think, are going to end up having their most important role early in disease, when people have mild to moderate infection. So these are the antibodies that we're going to be discussing, but a variety of antibodies, not just these two, are being studied for treatment and prevention. The antibodies that we'll be talking about today target the spike protein of the SARS-CoV-2. And you're aware that 2 emergency use authorizations were issued for treatment of ambulatory patients with mild to moderate COVID-19, with the additional specification that they be at high risk for progression and within 10 days of symptom onset. And during the Q&A, we can talk a little bit about how early these should be given. The 2 antibodies we'll talk about are bamlanivimab and casirivimab and devimab. So let's just start off with the antiviral effects and what we know about the antiviral effects. So for both these antibodies, in outpatients with mild to moderate COVID-19, the antibodies appear to accelerate the decline in the SARS-CoV-2 level in the upper respiratory tract compared to placebo. For bamlanivimab, this is a figure taken from the EUA document, and you can see the placebo is in red. This is the viral load over time, going out to 11 days, and then the antibody, 3 different doses of bamlanivimab, are in the dashed lines. There is a separation in the viral load decay. It was statistically significant for the intermediate dose at day 11, but there does seem to be a separation between the antibody and the placebo. Here are analogous data for casirivimab and devimab. These are in individuals who had a positive SARS-CoV-2 viral load to begin with. Not all patients did in this particular study. But you can see the placebo is in blue. The antibody, 2 different doses here, are in the other colors. And you can again see a separation. I want to make a very important point here about the casirivimab and devimab. The largest reduction in viral load is in participants who were seronegative at baseline. That is, who did not have their own endogenous antibody at the time of enrollment. And that's important because a number of people will develop their own antibodies over time. So the earlier in the course of the disease, the more likely it is that the person does not have their own antibody, and probably the most likely place where the antibodies will have an effect. Let's go through a little bit of the clinical data. And the reason I go through the clinical data is because the EUA was not granted based on the viral load effects that I just showed you. We don't yet know in COVID-19 whether the viral loads, changing them, confers clinical benefit. We know that for diseases like HIV, but we don't know that for SARS-CoV-2. So I believe that the FDA largely based the EUA on these next 2 slides. So let's do bamlanivimab first. In a little over 450 outpatients with mild to moderate disease who were enrolled within 3 days of a positive SARS-CoV-2 test, there was a numerically lower rate of ED visits and hospitalization in those who got bamlanivimab versus placebo. So in the bluish coloration on the top right-hand side of your slides, you'll see all of the participants, the 450 or so. The placebo group, the rate of hospitalization, ED visits, was 6%. In the pooled antibody groups, it was 2%. But then look at the bottom table, the one on the bottom right, that's showing you among high-risk patients. The high-risk patients we'll define in a moment. But here the difference was 7 out of 69 in the placebo group, rate of 10%, and 4 out of 136 for a rate of 3%. So that was the difference. Time to symptom improvement was a little shorter in the antibody group, 6 days with antibody, 8 days with placebo. And importantly, the safety of the placebo and the antibody appeared to be similar. Let's do the same kind of process with casirivimab and imdevimab. These data are from the EUA. There's a publication also on this in the New England Journal, but these data are from the EUA. 799 people with mild to moderate outpatient disease enrolled again within 3 days of a positive SARS-CoV-2 test. Again, a lower rate of hospitalization in the antibody group compared to placebo. Again, look at the top right-hand side for the kind of the bluish background. 10 out of 231 in the placebo group, a rate of 4%. 8 out of 434, 2% in the pooled antibody. But then when you zero in on the higher risk population, 7 out of 78 for placebo, rate of 9%, and 4 out of 151 in the pooled antibody, 3%. The reason why I'm giving you the numbers in part is just to underscore that the number of events is relatively low. The percentages are important and really are the why we think these are promising. But the numbers of clinical events in these data thus far are relatively low, and we will learn more for sure over the next weeks to months. The median time to symptom improvement was 5 days with the cocktail and 6 days with placebo. Safety of antibodies and placebo also were similar. There was 1 anaphylactic reaction, and there was 4 infusion reactions in the higher dose antibody group. So who should be considered for monoclonal antibody therapy? My colleague, Dr. Lennis, is going to go through this again, but I'll just briefly say that the expanded use authorization criteria really is those people who are at greatest risk for progression, obesity, chronic kidney disease, diabetes, immunosuppressive disease, age 65 years or older, or age 55 years of age or older, along with another comorbidity such as cardiovascular disease. There's a separate list for children, ages 12 to 17 years of age. All of the conditions on the non-age-based ones on the prior slide apply, but then in addition for age 12 to 17, you'll see them here and definitely worth attending to if you have a child who meets these criteria. So the reason why I wanted to put up 2 additional slides is many of us have been thinking a lot about how do we tier risk? Who is at greatest risk for developing hospitalization? And so I want to just bring up 2 data slides, one from the UK, one from the US. This was a study that was published in the summer or late summer, early fall. 17 million people in the UK, about 11,000 COVID-19 deaths. I put up some of these hazard ratios so you can get a sense of how great of a risk different populations have when you adjust for other comorbidities. So age for sure is the greatest risk. Look at that hazard ratio of 20 for a person 80 years old or greater compared to a person in their 50s. A hazard ratio for death of 20. Males with a greater risk of death than females. Organ transplant also has a fairly substantial hazard ratio of 3.53. Recent hematologic malignancy within a year, rate of almost 3-fold compared to, again, people who don't have that condition. Obesity depends on the degree of obesity. It ranges from 1.4 to 1.9 depending on the BMI. Diabetes depends on the hemoglobin A1C and the control. Those are the hazard ratios. Respiratory disease. And then having chronic renal insufficiency with a GFR of less than 30 has a hazard ratio of death of 2.52. So they're not perfect tiers, but they give you a little bit of a sense. The CDC comparably has some data from what's called COVIDNet. These are their adjusted rate ratios. Not all of the same conditions as in the previous slide are on this slide, but you can see some rate ratios here for hospitalization. This is not for death, but for hospitalization. But I put up this table just to say that in people who have more than one condition, they have a correspondingly greater rate of hospitalization. So someone who has 3 or more high-risk conditions has a substantially greater rate than a person that has one. A person that has one, depending on the condition, has a greater rate, of course, than someone who has no high-risk conditions. And then these are some of the other things that the CDC identified: age, of course, male sex, non-Hispanic, Black, and other race ethnicities. 1 or 2 slides on hospitalized patients. I know that's not the focus here, but this is what we know about patients hospitalized due to COVID-19. Bamlanivimab was studied in hospitalized patients who did not have end organ disease. This was part of the ACTIV-3 study. They were randomized to receive the antibody or placebo. This publication is from last month, but it was stopped for futility after a little over 300 patients were enrolled. You can see in the red, the antibody, and the blue placebo in terms of time to recovery, and really no difference once a person is hospitalized. And I think this speaks to where they are in the course of the disease. Some press releases on the casirivimab and imdevimab, the study that was looking at patients on high oxygen requirements with this cocktail was stopped in late October. More recently, end of December, some press releases indicating that there may be some positive results in people who are hospitalized on low flow oxygen. But at this point in time, we don't have enough data to make a determination. And the cocktail is being studied in the recovery trial as well as in the ongoing trial. That's the topic of this press release. But the EUA is really just focused on outpatients. It's not authorized right now outside of a clinical trial for inpatients. So I promised people that I would stay on time. So my second to last slide, this just again reminds us of the spectrum of disease, with dexamethasone really having a role in severe to critical disease, remdesivir having a role in severe illness. And I think where antibodies are likely to have their role is in mild to moderate disease. So this is my last slide with my own perspective on this topic. I do think monoclonal antibodies show promise, but with the data at hand, it's difficult to be certain as to the magnitude of the clinical benefit and which patients are most likely to benefit. For that reason, I think more data from the ongoing clinical trials are needed, and we continue to refer patients to those trials, such as the ACTIV-2 study, which is an NIH-sponsored Operation Warp Speed trial. For high-risk patients who are not eligible or interested in clinical trials, or if a trial is not available at your site, I think it's very reasonable to discuss the potential benefits and risks of receiving the monoclonal antibodies through the EUAs as part of a shared decision-making process, and my colleague, Dr. Lennis, will describe our efforts in that regard. There are no comparative data to determine whether there are differences in efficacy or safety between bamlanivimab versus casirivimab plus imdevimab. And then I think monoclonal antibodies should not be used in patients hospitalized due to COVID-19 outside of a clinical trial. And the ACTIV-3 trial that gave us information on bamlanivimab is ongoing. So I will stop, and I hope that I've kept to my 10 minutes, and I'm happy to take any questions or comments and look forward to the discussion.
Raj, thank you for that concise but very comprehensive overview. First question I've got is about timing of administration, and wondering if you have any evidence or sense that rapid treatment within a day or two might be better than treatment after 2 to 3 days. Is treating earlier better, or is just getting treatment within that treatment window similar?
It's a good question. My own opinion about this is that the earlier the better. The reason I say that is we know that people will develop their own endogenous antibody over time. And I think where these antibodies are probably going to have their greatest role is in that window before a person's own immune response kicks in. And so I think in that regard, the earlier, the better. It's not a perfect analogy, but there was a very recent publication on convalescent plasma. Convalescent plasma is different than monoclonal antibodies, but is thought to have a similar, at least in part, mechanism in terms of antibodies having an antiviral effect. That publication in the New England Journal of Medicine last week was from Argentina. And that study, the difference was substantial between placebo and convalescent plasma, but people got the convalescent plasma within 3 days and really within about 2 days of symptom onset. So it was very, very quick. And so if I had a person, I think the earlier the better. The EUA authorizes it out to 10 days. And I think the reason for that is because in the trials, patients in those trials had symptoms for different durations, but all within 10 days. In those trials, I highlighted this before, and then I'll conclude with this answer. It was within 3 days of a positive test, and it was also relatively early in terms of symptom onset. It was within 3 or 4 days of symptom onset. So the earlier, the better, I think.
Great, thanks, Raj. For this part of the program, I've only got time for one more question, but what do you say to colleagues in facilities who are contemplating monoclonal antibody administration that are hesitant given resource constraints and limited published data at this time?
Yeah, that's a good question. I mean, the guidelines committees thus far have, because of the relatively low numbers of clinical events, haven't endorsed them as part of standard of care because these are early stage trials. I think they are promising, and for people who aren't eligible for trials, I do think shared decision making around this and setting up programs to deliver it early are very reasonable. The issues that come up, and I think Dr. Lennis will speak to that, is it is a investment of time and resources, and it's a time where we're trying to keep people out of the hospital, also get them vaccinated, also care for people in the hospital. So it's a very challenging time, and I think the more resources we can bring to bear on this, the better. I'm happy to talk about that more in the conversation that follows because it is a critically important question.
Great. Thanks, Raj. I'm sure we're going to come back to that. And maybe, Inga, if I could ask you just to pull your slides down for a moment. I'm going to hand the mic to my colleague, Dr. Christian Ramers, who, as I said, is the Chief Medical Officer at Family Health Centers of San Diego, also an infectious disease physician. Christian, over to you. I know we're going to do a polling question next.
Great, thanks, Bruce. And if I could just ask everyone for your questions, put them in the Q&A box instead of the chat, and we can track them and actually answer them more easily. So before we get to Inga's talk, I want to do a polling question. We do this every time just to sort of check the pulse of the audience. So Amanda or Amy, could you bring up the polling question? Question is just a simple one. Has your healthcare facility or system infused any patients with COVID-19 monoclonals? And I'll give you 5 more seconds so we can move things along. Great, we've got more than 600 of you on the call, so I think we get about over halfway, we can stop the poll. Okay, that looks good. So more than half of you have been infusing monoclonals, and it looks like another quarter are probably thinking about it. Great, that's why we're all here, so we can take the poll down. Thank you. All right, for the second talk, it's my pleasure to introduce Inga Lennis, who is Senior VP of Practice Improvement and Patient Experience for the Massachusetts General Hospital and the Mass General Physicians Organization in Boston. Dr. Lennis oversees the management of a large ambulatory enterprise across MGH clinic sites where 12,000 patients are seen per day, and she's going to share the experience of Mass General with monoclonals. Over to you, Inga.
Great, thank you. Can I get a nod if you can see my slides? Yep, great, super.
Great.
It's wonderful to be with all of you. Thank you for the invitation. I'm going to really focus on some of the operational considerations. I happen to be an oncologist, so I'm pretty familiar with infusional therapy, but this has been a whole nother nut to crack over the last couple of months. So here we go. I'm going to breeze over some of the introductory slides because Dr. Gandhi covered much of this. I'll just highlight some of the challenges. Outpatient infusions for COVID positive patients. So bringing COVID positive patients into our areas. I think that we're more and more comfortable with this as time goes by, but it's always a risk of exposure. The scarcity of drug we have, and I would say even more than that, the infusion capacity to be able to deliver the drug. So one of the things I'll say is that there's an opportunity cost to using infusion chairs for this therapy, and that's something I want to make sure that I mention. So we are deploying this program in places like cancer centers or medical infusion areas in our hospital, and those areas are fairly full to begin with. So making sure that we can secure the staff to be able to do this and not displace, sometimes life-saving curative oncology therapy or other types of therapies are important, and it's an operational consideration. And then I would say also top of mind is the equitable distribution of these therapies. So this is the highlights of the EUA, which Dr. Gandhi went through already, and you can see them listed here. I will skip right through this. Our core principles when we're thinking about allocation, I would say equity is top of mind. As I said before, we have to ensure safety. In the beginning of these infusions, we had some evidence from the studies that have been done about the safety, but we wanted to make sure that we took all precautions very seriously. We know that we have to act quickly from the time that the test comes back to be able to get someone scheduled. And there's several different operational steps from the time that a test has resulted to the time that a patient is infused that have to be condensed and done very quickly. And then we want to make sure that we aren't curtailing research. So we have several active clinical trials in our institutions, and we want to make sure that we can continue to enroll appropriately to those research trials so that we're generating the data that will then answer the questions that we all have. And then we want to make sure that we're doing shared decision-making appropriately. This is a really interesting time to be in because as you're doing shared decision-making, as Dr. Gandhi said, the data for this are compelling, but we don't have a mandate that this is standard of care. So the discussion can be fraught and can be difficult. And when you try and operationalize that and ask every single referring provider to do a shared decision-making conversation and make sure that the quality of that shared decision-making conversation is standardized and really consistent, that's a very hard message and training to do over a very large group of individuals. So I'll tell you about how we've approached this because we started in a pilot phase in one direction and have pivoted based on some operational considerations, and I can tell you our experience with both. And then we want to maximize benefit. We want to make sure that we're giving this to the people who can benefit most as outlined by the EUA. So how do we identify patients for this particular therapy? We want to make sure that we are doing this in an equitable way and that equity favors entering patients into this system automatically if possible. And that's the way that we began. So at Mass General Brigham, which is a combination of 13 different hospitals, including Mass General and the Brigham Hospital, we have an automatic capture system where once a patient's COVID result is resulted within our electronic health system, a work queue is generated. The patient is assessed for eligibility automatically by standard structured fields that are entered into the EHR, including age and BMI. And then it surfaces a work list for our schedulers and for our clinicians to use to reach out to patients proactively who qualify based on those criteria, the timing of the test date, the positivity, and also BMI and age to reach out to schedule patients. We also designed into this an ability to sort for equity to make sure that we're holding spots for vulnerable populations, and we do that by zip code. We also have the ability to look through the work queue by various other socio-demographic factors to make sure that in our offering of this therapy that we're doing it in an equitable way and representative to the burden of disease in our region. Shared decision-making, we began with a process where we created a small group of clinicians that were at least bilingual and also trained in the shared decision-making process. They proactively reach out to patients who are on this automatic referral list to offer the therapy. We started that way because we had a real commitment to equity. We have moved to a point where we need to be able to place referrals in the state distribution of these drugs. One of the state mandates here in the Commonwealth is that we're able to offer these therapies to anyone in the state. So we are just debuted a referral process where patients can be referred into our process from a test that is outside the system. But that is not the way that we started. We started with just a smaller pool of people who had been tested within the system. And then we want to make sure, as we said before, that we enroll the ability to be in a research trial. I will say too that one of the questions that we considered is what does equity mean when we are in some degree of equipoise about how well the drug works. So we want to make sure that we distribute the drug equitably, and we have to consider this from both standpoints. Distributing it equitably from the standpoint of making sure that vulnerable groups are having access to it, but also that they're not disproportionately treated in the event that we find some new information in the future. I think that's unlikely to happen, but we want to make sure that we get the balance right on both sides. So what is our approach? As I alluded to, the EUA is broader than the MGB approach, and I want to make sure that that's clear. Our eligibility requirements for treatment include age and BMI, and then proximity of testing. So testing that's done within 4 days. We don't currently give this treatment to children. There's another institution in the Boston area that does have an allocation for children. So we are not currently treating children. And we chose to go with a stricter definition of eligibility based on the expertise of Dr. Gandhi and other ID professionals who are telling us that these were the most likely to benefit patients. And we knew that we have a very big health system. We take care of a large portion of New England. And so we knew that this would be a scarce resource and that we would probably be using a lottery to distribute the resource. So we wanted to make sure that we were narrowing the eligibility to the most, the group that could benefit the most. We use a lottery that's embedded within the EPIC system. Once patients are referred in either from outside or the automatic referral process, they enter into an automatic lottery that then gives us a work list, a prioritization list. We work from that prioritization list then to offer spots for treatment. The shared decision-making, as I said, was at first done by a group of clinicians that developed the training for it, and it was centralized. Those clinicians were mostly ID trained clinicians, and they need to go back to some of their regular work. And so we have now created training materials for all primary care doctors and all of the specialist doctors that might want to be able to refer in for this. So in order to place the referral, the providers need to actually do the shared decision-making, and I'll talk a little bit about what are the elements of that shared decision-making are. I'll mention this is in addition to our infusion, we also utilize an external company, the CVS Quorum Group, that is doing home infusions. It is a separate referral pathway outside of the MGB pathway, but we do encourage clinicians that want to avoid the lottery that they should use this particular pathway. CVS has slightly different criteria for administration than our central MGB criteria, and as far as I know, they don't have an equity sort or a lottery, but it's another resource. And I do think home infusion is really appealing because of that issue that I brought up in the beginning with opportunity cost for treating other patients. So in the slides, and you'll be able to look at this later, but these are just to make the program a little bit simpler. We put it into a graphical format in a table so you can see how we look at patients and what programs that how we would categorize them for infusion therapy. I'll just end by giving some pearls. This is how we train our clinicians on doing the shared decision-making conversation. One is that we specify that they need to ascertain assent, and the EUA requires that. The goal is really to have an informed decision-making conversation. We talk about the eligibility requirements. We have to talk to them about some of the operational details. Some of this work is being done with patients completely virtually. So a provider may not have even seen the test result. They may have been called by the patient and told about the test result. The patient needs to know that when they arrive for infusion, they have to bring their test result with them so it can be verified. And if it is outside of our window, they won't be treated. So there's some like counseling that has to happen with patients. And yes, we do ask that patients be symptomatic. So the symptoms are wide ranging, but a completely asymptomatic patient would not be eligible for our program. These are some of the key points that we go over with patients as what is a monoclonal antibody. Practical information about the infusion. We need to tell them how long they'll be infused for, and we often have to arrange for transport. This is a program that brings patients to the main hospitals from all over the state. What the EUA means, and then a summary of what's known about these therapies and what the potential benefits are. And then a big one, which I see has come up in some of the questions, is a discussion about vaccination and how this might impact vaccination. So we recommend that vaccination not be given within 90 days of this therapy, but I think that is to be determined, but that is based on the evidence and the expert guidance that we have so far, that has been what we have been telling our patients. Pregnancy and breastfeeding. We've had many pregnant patients who have become eligible for this patient, and they have lots of questions. We tell them what we don't know according to the evidence, and we usually involve a maternal fetal medicine specialist as well to help with discussing the case. The The lottery. So we also have to tell patients that even if they are referred for this therapy, that there is a lottery that's done prior to scheduling. And setting appropriate patient expectations is a big part of what we've learned. This is very hard, and it's hard to do a shared decision-making visit with patients and then let them know that they weren't prioritized in the lottery. So we're working through a lot of that scripting. There's some links and information in the slides, which will be available to you, and I'm happy to take any questions. Thank you.
Inga, great. Thank you so much for sharing your experience there. I think we just have time for maybe 1 or 2 questions for you. The first that I have is about equity. So I mean, you mentioned equity. It's really a tough thing to balance. And I'm thinking specifically about, since you have such a wide region that you take care of, have you run into issues with transportation? Number 1, and then secondly, a question came in through the Q&A about insurance. What do you do for an uninsured patient? Are we able to even offer this for those people?
Yes, so we do currently, the cost of the drug is, I'll take the second question first and then go back to the first. The cost of the drug is covered by the state, and the infusion costs, we have had no problems getting insurance coverage for the infusion costs. If there is a completely uninsured patient, there's some pathways that we can explore within our own institution to cover the cost of the infusion. Once the drug, once we are out of this period and we have to do a prior authorization for drug costs, that will be a different discussion, I think, and we'll have to come up with some different alternatives. Yes, transportation is a huge issue. And that's the balance we have. We decided to do these infusions in a small number of places in the cities. And that means that people have to travel a long distance to get there. We have an arrangement with a chair car and with different ambulance companies, and we have had to subsidize transport to get patients here.
Okay, great. For the interest of time, I'm going to move us forward, but thank you so much for sharing. I hope you'll stay on for the panel. So we're going to move into the second half of our discussion here. Raj is going to stay on, as well as Inga have already been introduced. I'm happy to introduce Michelle Ritter, who's joining us from down the road from me, San Diego. She's the Director of Infectious Diseases COVID-19 Clinic at UC San Diego, and has also served as the co-chair of antimicrobial utilization, and is the Clinic Medical Director of the Division of ID at UC San Diego. Also from San Diego, Lucy Horton, who's an attending in the Division of Infectious Disease at UCSD, and who's part of the COVID-19 telemedicine clinic. We also have Justin Guajardo, who is the Director of Nursing at Sunrise Nursing and Rehab in San Antonio, Texas, and has been in the nursing profession for 10 years and has amazing experience to share from an outbreak situation in San Antonio. And also from San Antonio, Lisa Washington, pharmacist and pharmacy director from San Antonio as well. I think what we'll do is start with some clinical issues, and then we'll move into specifically the situation in San Antonio to have our guests share. And I should mention Carol Cunningham is also joining us, Medical Director of EMS at Ohio, and then Rick Hunt and David Wong, also from HHS and Operation Warp Speed. So let's jump right into the clinical questions. We've had a couple come through about which patients should be excluded from treatment with monoclonals. And Raj and Inga, I want to get your opinion on this specifically. One question about people that were on oxygen previously. Let's say they had stable COPD and they're on two liters of oxygen. Do you have to exclude them because they are on oxygen at the time of therapy?
It's a good question. I think if they're on a stable amount of oxygen, it's attributable to a pre-existing condition, then I would think about them differently. If you're not going to be admitting them to the hospital, that is, their oxygen hasn't increased, then I think they would be a reasonable person to have this discussion around and then consider the antibody if they're interested. I don't know if Dr. Lennis, you want to comment? Or?
I agree. Yep. If it's a stable and no change from baseline, that's how I would define it.
Okay, and another clinical conundrum here about vaccination. We've heard a lot about this, and actually an anonymous attendee asked the question that one of their ER doctors received the first dose of Moderna vaccine, and then the day after became feverish and tested positive for COVID, and wants to know if receiving bamlanivimab will blunt the effect of the vaccine in any way. Raj, you want to take that one?
You know, I wish I knew the answer. I don't think we know the answer. I think our approach, or the way we're thinking about it, is that if someone has gotten the first dose of the vaccine, we're a little worried about then giving the antibody if they develop COVID between the first and the second dose of vaccine. So that's how we've been thinking about it, but I can't point you to anything definitive on that.
Thank you. I'll share that Janet Woodcock, therapeutic lead for Warp Speed and from the FDA, mention that there is some discussion about at least waiting 2 days after the vaccine, because it's thought that the mechanism of the vaccine, the uptake of the mRNA and expression of spike would maybe take 2 days to occur. And if you give monoclonals immediately after that, you might blunt that. And then we've also mentioned the 90-day deferral after receiving monoclonals. I'm curious, Michelle and Lucy, if you've had this in San Diego. To me, giving a vaccine to somebody who is already immune doesn't make any sense at all. And so the 90-day, although it causes so much angst with people wanting to get the vaccine, doesn't bother me too much. Lucy, do you have an opinion about that?
Yeah, so we've been following the CDC guidance, which is to wait the 90 days after administration of the monoclonals. And that goes along with waiting 90 days after a natural infection as well. So that's what we've been doing to date and what we plan on doing in the future.
And Michelle, anything to add?
No, just that we have been in the position. We've had a few employees who've gotten sick within the week after getting their first dose of the vaccine. And so it's been a risk benefit discussion about whether or not to give them the MABs. And we've given 2 employees Regeneron after Kezaribimab and Devimab afterwards. And both have done okay. But the big question is, what are we going to do with the vaccine? And we've kind of explained to them probably 90 days, but that the recommendation could change as far as when maybe we would give them another dose of the vaccine or restart the vaccine. And we're kind of working with our virologist to kind of help determine what to do. But again, we're looking just at risk benefit ratio and times where we think maybe it's worthwhile still giving it to them.
Thanks. And another question to the 4 of you before we move on to the San Antonio experience. There was a question about whether it matters if somebody gets a RT-PCR or a antigen test before receiving monoclonals. Any opinion on that, Raj?
My sense is either would be fine. And someone who's symptomatic with suspected COVID-19, I think if you have a positive antigen test or a positive PCR, either would be fine to rely on.
And one additional thought while you were presenting, Raj, that occurred to me, the data does really differentiate between those who are seronegative and those who are seropositive. I remember thinking about point of care antibody tests a long time ago and thinking there was no real clinical role for them. But is there a thought that a rapid antibody test might help you differentiate people who would most benefit from monoclonals?
People have definitely thought about that. I'm not aware of the availability of that, at least at our institution. The EUA does not require that. One thing I may not have said, but maybe I'll say here, is in the New England Journal paper for Kezaribimab and Devimab, they did give a figure of how many people were seronegative. It was 41% of the people in that study, 275 people, not the full EUA population, but a subset. 41% were seronegative, and that's where a lot of the viral load benefit was. So yes, it would be, in a perfect world, if we had all the access to a rapid test, I think that would be a very interesting thing to see. Could we target the antibodies to those whose endogenous antibody isn't there? But neither bamlanivimab nor the cocktail, require that. So I don't know. Does anyone else on this call have access to or is using a rapid antibody test or not quite yet? No, I'm seeing some no's. Yeah.
I would presume you can use time from symptoms as sort of a surrogate for that marker as well. One last question. Oh, go ahead, Raj.
No, please go ahead. You're right. Yeah.
Okay. One last question for the 4 of you before we move to San Antonio is the age 55 plus comorbidities to me seems to be a little bit awkward. And I've heard many of you say that really above age 65 and BMI are the 2 most important factors. Michelle, would you agree? And how are you dealing with this 55 plus other comorbidities population?
Yeah, so we keep them in, we consider them anybody who meets the EUA criteria, but we do have a risk stratification scoring system that we worked on with ethics. And yeah, the highest points actually go to age over 65 and BMI greater than 35. And then we group the other risk factors as 2 points. We also add a point for being certain ethnicity or race that's higher risk, and a point for front-facing healthcare workers. And that's kind of a risk stratification tool we use to determine who gets seen first in our clinic and gets evaluated for these drugs.
Great, and I appreciate that Raj put the multimorbidity factor in there. I'm personally calling a lot of these patients, and when you look at their chart and they're just diabetes with very well controlled A1C of 6.0 versus someone with hypertension, diabetes, cardiovascular disease who's 60 or 70 years old, really different risk benefit there. So
maybe I'll just add quickly, the other population with this antibodies, I think time does track with antibody development, but in very immunosuppressed individuals, and again, this is not proven, that the trials we have aren't granular enough to do this, but in someone who has recently had cancer chemotherapy and or recent hematologic malignancy, I would be worried about them in terms of can they develop their own endogenous antibody, but the trials just don't have granularity on that.
Great. Okay, thanks. Let's move forward to give Lisa and Justin some time to describe their experience. So we'll start with Lisa. And again, just to remind everybody, Lisa's a pharmacist in San Antonio that had a really unique experience administering a lot of bamlanivimab in an outbreak setting. Lisa, over to you.
Absolutely. I wanted to just go over basic timelines for dispensing and distributive functions that we utilize for bamlanivimab. At PharMerica, initially we received notification on December 17th from our Senior Vice President, TJ Griffin, that we would be receiving allocations of bamlanivimab. 2 days later, on December 19th, we received an initial 20 doses of product. And on December 21st, I was contacted by Justin Guajardo. He's a director of nursing at one of the long-term care facilities that we service out of San Antonio, that there was a prescriber interested in ordering monoclonal therapy for a number of COVID-positive residents. Justin and I reviewed some of the baseline logistical issues, monitoring requirements, emergency medications that were at his disposal in the event of an infusion-related reaction or anaphylaxis. We also looked at the relative stability of the product after mixing. Stable 24 hours under refrigeration after mixing. So late on the afternoon of December 22nd, Justin began the process of sending in orders and finding assistance with IV access. On the 23rd of December, I performed the initial 14 dilutions of bamlanivimab in order to look at a time study and determine staffing allotment involved for my team members so that they could essentially replicate that process each time. It took approximately 45 minutes to transfer those 14 dosages to 250 milliliter saline bags. We prepped all supplies, and the entire process, start to finish, I would say 2.5 to 3 hours for 14 residents. Since we had a large number of patients impacted all at one facility, I decided to provide infusion pumps to help them facilitate administration. I will say, had we received orders from multiple nursing homes, we take care of about 35 nursing homes. If we had residents impacted at multiple homes, it would have been much more difficult for us to provide infusion pumps. And in that case, gravity infusion, dial-a-flow is perfect, would be more feasible. Staging and timing of the dilutions were critical. And so I assigned an IV tech to type in prescription orders, pull supplies, stage IV pumps and pulls while I worked on the dilutions. For the initial 14 dosages, again, turnaround time was roughly 3 hours. We set up a courier to be on site so that as soon as I came out from the hood, we could actually push everything out to the facility. Again, keeping in mind that the product's good 24 hours after it's mixed. The following day, which was Christmas Eve, we sent an additional 6 dosages, and we put an exchange process in place to retrieve used pumps. Late that evening, Justin notified me that the prescriber was interested in dosing potentially 20 more patients. Well, we'd exhausted our entire shipment in 2 days. So I made a 911 call to our senior VP, see how I can get more bamlanivimab. And we were successful in coordinating a transfer of 20 dosages from a sister PharMerica location in El Paso, Texas. We received the product on Monday morning and were able to push out 6 more dosages on Monday, and the next 2 days we repeated that process. So overall, we dispensed 38 dosages of bamlanivimab. was over a 2-week time frame. However, there were only 5 distribution days and 5 administration days involved in the process. And so I guess more importantly, Justin and his team at the nursing home, they were able to successfully administer 38 dosages in 5 days, which I think is phenomenal. And so I'm going to take the opportunity to segue to Justin to discuss administration and some of the successes that he had as well.
Yeah, sure. So some of one of the biggest questions is, how was I going to have the manpower to do this? We all have those struggles, especially during a crisis situation, outbreak. And it was clear to me at the beginning that the nurses working on the floor were not going to be able to absorb that into their day. And so it was then that I decided, and I think this was the most important part about it, deciding that we were going to do it, begin with contacting the medical director, getting him on board. And then, of course, coordinating with Lisa. And then, I figured, well, I'm a nurse, I can do this. So I pretty much spearheaded the entire project from point A to Z. And I think looking back on it, that's kind of one of the most important things, that there was one person at the facility involved with coordinating with Lisa at the pharmacy, making sure she had her orders and what she needed. I had what I needed. It was going to be delivered at the same time every day. I would receive it from the courier, get the equipment, set it up in the patient's room, begin trying to insert IVs on patients. And then I had an IV infusion nurse that I also had called in to help me insert IVs on folks that I couldn't get. And then I administered the product after that, and then monitored the patients. And I think that was the biggest part about the success, just having one person involved coordinating it. Of course, the team helped me immensely on the floor, but they couldn't have handled the entire process. It was very time consuming. And we don't have a lot of resources that are dispensed, especially at a time like this. So I just decided, like I said, to sort of spearhead the entire thing. And I think that was part of the reason why we were able to do this over that short amount of time, because I was familiar with the process, I was efficient with it, and it was just me kind of directing everything. And so, I mean, I'm happy to, I would like to see this be the norm in the long-term care setting, and anything I can do to help propagate that or answer questions or concerns about it, I'd be more than happy to do. But I'd say the first thing to do is commit to saying you're going to do it, and then get a plan together, work with your medical director, work with your pharmacy, work with your infusion clinics to try to figure out how you can get it done. And then, just take it one step at a time, and you'll get there like we did.
Thank you, Justin. And one of the great things about these forums is just to highlight the heroic work that's happening on the local level. So congratulations for what you're doing and for serving as an example. One clarifying question that came in is, your facility, is it skilled nursing facility or assisted living, or what type of place?
It's a skilled nursing facility, that's correct.
Okay, great. So we've got just a couple of minutes left to hit about 70 more questions. One that seems to be consistently coming in again is the timing of vaccine and monoclonals. So let me go back to you, Raj. In terms of someone who gets a vaccine within the first 10 days after the vaccine or so gets sick, is it safe to give monoclonals in that setting? And would you? And then secondly, what would you do with a second dose of the vaccine?
If they got the first dose of the vaccine 10 days ago, would I give them monoclonals? Honestly, I think we have been following them carefully, but not jumping in with the monoclonals. I'm now speaking personally. I don't think there's a right answer to this. Dr. Lenz, do you remember, have we had that situation arise in the last 4 weeks in terms of giving monoclonals to someone who got the first dose?
Yes, we just have had it in this past week, and we have not given the monoclonal antibody. I believe there's a trial open with another therapy that isn't antibody.
Not an antibody, it's a camostat, perhaps, yeah. Which is a non-antibody based treatment. So that might, it depends, I guess, on what you have available locally, but we haven't. It sounds like UCSD has those, so you're going to get some differences of practice on this because it's just too new. So.
Michelle, you want to address that?
Sure. Yeah, I think it is a really tough situation. We have a COVID therapeutics task force that we kind of go to with these difficult questions, but we've done them on a case-by-case basis. We did have one especially high-risk patient, just morbid obesity, multiple medical problems, who had gotten the vaccine 4 days earlier, and the decision was to give it to her. And she's done well, but again, we don't know what this means in terms of her antibody, the vaccine, what to do with her in the future, and she understands that. But again, just case by case, risk benefit is how we've gone into these, with a lot of we don't know. We don't know exactly what's going to happen.
What did Dr. Woodcock say? She said 2 days, but did that imply that if it was 3 days, she would give the monoclonal? I'm asking whoever was on with Dr. Woodcock.
Yeah.
Christian,
I don't think this has been officially penned in any kind of guideline, but looking at mechanism of uptake of mRNA, production of spike, you would at least want to allow that process to happen before flooding somebody with monoclonals. It reminds me of giving, H-big and hepatitis B vaccine to a newborn baby at the same time in opposite arms, not wanting to step on each other's toes. But yeah, I think it was just a discussion amongst the Warp Speed and FDA folks about 2 days being an adequate time. Lots of questions coming in about outcomes, and I think we're all waiting for more data on outcomes. Raj, anything in the horizon that we think is coming, either an observational experience or more trial data?
I'm being told, including by some people on this call, that some observational data is being shared and may be shared in the near future. That will, of course, help. I think the randomized trials are rapidly enrolling participants because of so much COVID out there. And so I'm hopeful that we'll have information there, not only on the 2 antibody products that we've talked about, but Active-2, which is the NH-sponsored, Operation Warp Speed-sponsored trial, is looking at a couple of different antibodies that have different unique niches. So a lot more to come just because of the numbers of COVID cases. So.
Great. And then I want each of you to kind of weigh in briefly about safety. We have a whole session, I believe it's next week, David, dedicated to how to respond to reactions to the monoclonals, but maybe we'll start in San Diego. Lucy and Michelle, any adverse reactions that you're seeing, Lucy?
We haven't seen any severe infusion reactions, which has been really great. We have seen several patients who do develop fevers the evening after receiving the infusion, and these usually resolve by the next morning or resolve with Tylenol, but no severe reactions.
Michelle, same thing?
Yes, no, it's absolutely right. People with kind of mild symptoms. We've had 2 patients who developed Rigers. One were more severe, and that patient did get Demerol and they resolved, but that's been the extent of it for us. And that was, again, right after the infusion.
Inga?
Same, no serious infusion reactions.
Okay, and Lisa in Texas?
None that we are aware of, no.
And Justin, to your eye at the bedside, anything that you've seen?
There was no major side effects. I would say that we did have a couple people that had a slight drop in blood pressure. No intervention was required to handle it, though.
Okay. One question that came in on the chat, I think it might have to be our last one, is about giving monoclonals in the emergency department. Maybe Carol, I'll ask you, in Ohio, are you aware of emergency departments having success, and is that clogging up an otherwise busy ER?
In Ohio right now, we're in crisis, so it would clog up our emergency department. So we're not doing it in that facility.
Anybody else aware of ERs using this?
We don't use it in the ER, but we contact patients discharged from the ER because they'd be eligible.
Okay.
I will say the EUA says not to use it in someone hospitalized due to COVID. So if I had a patient who had mild to moderate symptoms, extremely high risk, was in the hospital for a broken arm, or I don't, maybe they didn't hospitalize for broken arms, but for some other reason, it's due to COVID that the EUA cautions us not to use it because of that uncertain data once they're hospitalized for COVID. So that's maybe a distinction that might help.
Great. Yeah, and I have heard of other examples of an unrelated hospitalization or somebody in long-term
care. But have mild to moderate symptoms. Yeah.
So we're just about out of time. I want to pitch over to David. First, a question for you, David, and then allow you to wrap up. Just a couple of words about the SPEED program in terms of allocation of doses. It seems like in San Antonio, that was exactly what they utilized. Could you comment on that and then wrap up the session?
Yes, absolutely. Thank you, Christian, and thank you to all our speakers and panelists today. As far as the SPEED program, this is the program that we use to get the bamlanivimab to the nursing home and the long-term care pharmacy in San Antonio. And this is a program we started about 3 weeks ago, and it's really to have direct federal allocations to settings that care for high-risk patients that are at risk for hospitalizations. And those 4 settings, besides long-term care, include dialysis centers, correctional facilities, and federally qualified health centers. And so through the SPEED program, we've administered over 20,000 treatment courses to date, and that number keeps growing. And then as far as this session, I know we're at time here. I just want to highlight where it's very much a user-generated responsive system. And based on the polling data we did a couple weeks ago, our next two topics, we're actually going to skip next week because of Inauguration Day. So the next session will be on January 20th, and that'll be on managing infusion reactions. And that, again, based on what folks were suggesting as potential topics. And then the week after that, which is February 3rd, we'll have a session dedicated on patient and provider outreach. So with that, I want to thank everyone again, and we'll hand it over to Bruce for final comments.
Just thank you to all our, thanks to Raj, to Inga, Lisa, Michelle, Justin, Lucy, Carol, David, everyone, and to all the participants. There were over 600 participants. Christian, thanks for the great moderating. Please fill out the CME, CE, give us your feedback, and we look forward to seeing you back in 2 weeks. Take care. Thanks, everyone.